name is Rebecca Wagner. We're going to be going over community-acquired pneumonia.
My name is Hannah Grominger.
And my name is Peyton Lehman.
A community-acquired pneumonia is an acute infection of the lung parenchyma, so the alveolar sacs, ducts, and into the bronchioles. And for it to be considered community-acquired, it has to have been contracted outside of the hospital. So symptoms have to show up before a patient is in the hospital, and if they're in the hospital, before they've been there for 48 hours. The causes of community-acquired pneumonia fall into 4 categories: typical bacteria, atypical bacteria, fungi, and viruses. The 2 most common causes, typical bacterial causes, are strep pneumoniae and Staphylococcus aureus. And then also on the viruses, influenza, coronavirus, some of those. And then some risk factors that increase the patient's chances of contracting pneumonia would be being over the age of 65 and other chronic lung diseases, diseases that affect the immune system or major organs, and smoking, or recently having an upper respiratory infection. And many of these also increase the patient's chances of having severe pneumonia, being admitted to the hospital, or even dying from community-acquired pneumonia. Most common symptoms of community-acquired pneumonia are cough, dyspnea, and pleuritic chest pain. The cough usually is productive, producing this like rust-colored sputum, but there are some exceptions with different causes. So like Klebsiella is associated with current jelly sputum, and these are chlamydia, HIV related, are associated with no sputum production. And then there's also systemic symptoms, so fever, chills, fatigue, and headaches. And then when you're getting the history, you do want to ask if the patient has ever been exposed to pneumonia recently, if they've had an upper respiratory infection recently that might have moved down into their lungs. Also, if they've had any recent travels, because different regions of the US are associated, they'll make you consider a certain etiology more highly. Also ask about exposure to birds, fleas, rodents, and then if they have any chronic lung diseases, if they smoke, really pointing back to the risk factors and asking about those.
Okay, and then for the physical exam, there is tachypnea, crackles, bronchi, agophony, tachycardia, and then there can be worsening symptoms like hypotension and altered mental status, so you would consider sepsis at that point. And then to help rule out differential diagnoses, you would do them by percussion, tactile affirmatives, and components of the physical exam. So for diagnostic studies, you would have things like chest x-ray, which there you could see infiltrates, effusion, consolidation, and air bronchograms. And if they have a negative chest x-ray, then you would want to get a CT of the chest if your clinical findings were more positive for CAP. And for the labs, you would do CBC with differential, flu and COVID testing, just to rule that out as well, and a CMP checking your kidneys and liver, as well as blood sputum cultures. And then you can do procalcitonin to help differentiate the viral from bacterial etiology. So here are some examples of some chest x-rays. So on the first one, you're gonna note the left lower lobe opacity on the side there. On the second chest x-ray, you can see that there are ground glass opacification with early consolidation, and the other shows the left-sided ground glass. And then the last x-ray here, you can see that there is a lung abscess with air fluid level in the right lung, and then there is necrotizing pneumonia in the left lung here. And as far as our treatment plans for patients who are otherwise healthy and have not recently been on antibiotics, you'll treat them with amoxicillin plus a macrolide or doxycycline, which macrolide is preferred. Patients who have major comorbidities, maybe smokers, and who have used antibiotics in the past 3 months, you would do oral amoxicillin clavunate twice daily with macrolide, which again is preferred over doxycycline. And so for most patients who are overall healthy with normal vitals, apart from fever, no concern for complication can be managed in an ambulatory setting. But for patients who have known colonization or a prior infection with MRSA, other strong suspicion, we add an agent with anti-MRSA activity such as vancomycin to either of the above regimens. And then patients with the oxygen saturation below 92% on room air and significant change from baseline should be hospitalized.
And going off of that, a big key part of the treatment plan is knowing when to hospitalize them, when you can do an outpatient setting, and especially when to send them to the ICU. So the criteria for this are going to be the CURB 65 criteria, which is confusion, urea, respiratory rate, blood pressure, and then the age above 65. So when diagnosing these classes, you can see that risk class 1 and 2 is going to be outpatient, 3 is going to be an out or brief inpatient setting, and 4 and 5 is for sure going to be an inpatient setting. And we're going to evaluate some major criteria and some minor criteria. The major criteria are septic shock, the need for vasopressor support, respiratory failure, and the minor criteria are just respiratory rate being higher than 30 breaths a minute, hypoxemia, hypothermia, hypotension, confusion, multilobular pulmonary opacities, and other things. So if one major criteria is met, or if 3 minor criteria is met, that is when you're going to want to send them to the ICU and have mechanical ventilation. So for our patient education, the most important thing about pneumonia is understanding how important the vaccination is. And when talking about the course of this disease, you can have some complications such as acute respiratory distress syndrome, pleural effusion, a lung abscess, empyema, and sepsis. And community-acquired pneumonia lasts about 5 to 7 days, with the fever resolving within the first 3 days. Muscle aches and shortness of breath for up to 6 days, but it's important to educate your patient that the cough can last up to 2 weeks. And talking about those risk factors again, just such as the age, smoking, immunosuppression, severe illnesses are key. And there's different strains of the pneumococcal vaccine with adults over the age of 65 or below that age range, but fit those criteria for being more at risk. And there's just 2 different strains of the vaccine that hit different conjugates parts of it. And secondary vaccines are also included in this, as well as the SARS-CoV-2 vaccine, the RSV vaccination, and influenza, especially for patients who are pregnant and can transfer it to their neonate and have underlying conditions. So first we're going to talk about viral acquired pneumonias. This is the difference in the strains of our assigned disease state. The etiology includes rhinovirus, influenza, and streptococcus pneumoniae. The risk factors are similar for both these disease states, with the age being above 65 years old. Chronic morbidities, comorbidities, what we talked about earlier, kind of exists in both these disease states. CHF is a big one. And smoking, the overuse of alcohol. And again, you're going to want to do a chest x-ray to be diagnostic in both these diseases, and prevention is also key, as talked about earlier. But when talking about bacterial acquired pneumonia, that's when there is a lot more severity to it. So the etiology is, like as we said earlier, strep pneuma being the first one and staph aureus being the second most common. H. influenza is also another etiology, and we went over etiologies earlier, but that's just some examples of them as well again. And a chest x-ray is again used on both of these. Prevention is going to be key, again, as we said, and patient education is most important in these disease states. And when talking about the severity of the disease, higher risk factors exist for bacterial community-acquired pneumonia, such as prior isolation of the pathogen, inpatient hospitalization within the last 90 days, or exposure to IV antibiotics in the last 90 days, so they're just at more risk for getting worse with the disease. And last are some atypical bacteria. We talked about it earlier, but just some key differences to point out is mycoplasma or walking pneumonia, which can have a complication of otitis media and bullous meningitis. Klebsiella pneumonia, like she said earlier, just that current jelly sputum. Lung abscess on the chest x-ray. HIV is going to be a bit more serious. You want to get them Bactrim DS and Dapsone if they're allergic. And then fungal cases, as we talked about, as blastomycosis, histoplasmosis, and being cautious in the patient history taking of where they've traveled, things like that. And lastly, the most important are the differences in the treatments for those, such as doxycycline for the chlamydia, Sataki, and azithromycin for that tularemia pneumonia.